Hey, good morning, everyone. And sorry we're late. I actually thought we were live, and it turns out we weren't live, but we are now. So, hey, who cares? As long as we get on the air. I'm your host, Vic Sinise, and welcome to the show. Got to learn to look for that button that says I'm actually broadcasting. So now, if you're watching us from any of our areas that we're now going live to, welcome, excuse me, welcome to the show. Hit that like and subscribe, even if you don't like us because we were late. This is your first time checking us out, be sure to go to our uronurse.com website to learn more about the show. Best place to go to see all of our past episodes, all 92 of them to be exact. Also, you want to hear us in your car, go to our Uronurse Plus area and download our link up to one of our audio podcast formats. Great place to hear us. And you patients that are watching, check us out at 10:30 on the europatient.com, where we do our Europatient podcast every Saturday following this show. Also, if you want to get our newsletter, be sure to subscribe on our website. And this week, or not this week, we're on June 29th, put it down on your calendar. We're going to celebrate our 100th episode, and it's going to be a special episode. We're going to be having giveaways. I got these special credit cards made up from MasterCard with our logo on them, and we're going to be giving those away. As a matter of fact, you have to be live in order to enter the raffle, but for every 10, let's see, 10s like that, 10 people that subscribe or come and watch us live, I'm going to go ahead and give away a card. So you have 1 in 10 chance to win. Great one to watch. This week, we're joined by our expert, Lori Atkinson, who's going to be talking about pelvic pain. And it'll be a great show to learn everything we need to know about pelvic pain. And I had a quick clip I'm going to show you guys on that's something that I saw today as I do my little intro here. So today I was out in the back of my house and I found a cicada. And, they say they're coming. Watch out. This is a live cicada. He's not moving too much, but his wings are drying out in his shell. So it's kind of a cool thing to see. With that, let's go ahead and bring our experts into the show. Experts, welcome to the show. All right. Seems like we just did this, right?
We did.
So for those of you watching, we've been chatting along, doing all this thinking we were there. So I'm going to cut mine brief. Vic Sinise, welcome to the show. John, go ahead and give us your intro.
Good morning, everyone. I'm passionate about helping urology practices succeed so they can reach maximum clinical and financial efficiency. To that end, I created the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit, and it's all for free. And when they say it's free, I say I'll take 3. I frequently speak on the topics of coding, billing, revenue cycle management, marketing, and just how to run your practices more efficiently in the era of declining reimbursement and rising practice overhead costs. I just spoke at the AUA annual meeting in San Antonio a couple of weeks ago, and I'll be at the Texas Urological Society meeting in June, Louisiana Urological Society meeting in August, South Central Section AUA in October, and Urology Advanced Coding and Reimbursement Seminar in December. I'm John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today about the often bane of our existence, the pelvic pain patient. Back to you, Vic.
Yeah. All right, Lori, take it away. Give us your introduction, then we'll get you on the show.
Sure. Hi, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology for 26 years now, and I work for a large urology practice in Geneva and Winfield, Illinois, and happy to present for you today.
All right. And take it away.
So we're going to talk about pelvic pain, what you need to know. And I don't think any of us are really going to know everything that you need to know about pelvic pain. But we are going to talk about signs and symptoms. We're going to talk about the causes, diagnostic evaluations, treatments, and definitely symptom management. And we're also going to talk, obviously, because we're all in urology, we're going to talk about chronic bladder pain and also chronic pelvic pain in men. So, chronic pelvic pain is a very complex health problem. It's defined as pain in the area below the belly button and between the hips that lasts at least 6 months or longer. It can have more than one cause. It affects both men and women. It's so challenging to treat. But for these patients, it can be quite debilitating. It's a condition that impacts quality of life. Oops. So what is it? So it's pain. It can come and go. It can be constant. It can be dull, aching, sharp, cramping, and pressure or heaviness deep within the pelvis. The pain can also occur during intercourse, otherwise known as dyspareunia. It can happen while you're having a bowel movement or urinating or even sitting or standing for a long period of time. And of course, I have to talk about bladder-related symptoms, and these could be the suprapubic pain or pressure. It can have people can have the urgency or frequency to urinate. They have an increase in discomfort with bladder filling, and then they feel better when they void. They can have burning when they go to the bathroom or dysuria, bladder spasms, and urethral pain. Now the causes. Oh boy, this just is a little bit of what can cause pelvic pain. There's so many out there, but a lot of the common ones are the endometriosis. They can be muscle and bone pain problems, chronic pelvic inflammatory disease, fibroids, irritable bowel, the painful bladder syndrome, which is, of course, interstitial cystitis, which we're definitely going to talk about a little bit later, the pelvic congestion syndrome. It could be a pelvic mass. It could be menopause, menstruation, pregnancy, chronic prostatitis. We'll talk about a little bit of that. Of course, being in urology, I'm going to kind of focus on these urology conditions. Definitely a mental health risk factor. These people, obviously this condition can cause a lot of mental effects. Voiding dysfunctions, urinary tract infection, urinary retention, and even indwelling Foley catheters. So how do you evaluate this? A lot of times people present to their PCP. But depending on what could be causing the pain, a patient may be referred to, a gastroenterologist because they have digestive problems, maybe constipation, diarrhea, IBS, things like that. Gynecology, obviously, it could be due to the menopause or masses, there's so many things out there that can cause gynecological conditions. And of course, urology, which we'll focus on, is the urinary symptom problems. But sometimes it's both urinary and female productive system problems. So we refer to urogynecology for that. We also refer to physiatry or physical therapy because that really helps with a lot of muscle pain, skeletal pain, tension in that pelvic floor. Pain medicine is an option. And also sometimes people need to see a psychologist or a psychiatrist to talk about it. So what do you ask? There's so many questions to ask them. Where do you feel the pain? When did it start? Is it constant? Is it intermittent? How long does the pain last? How would you describe it? Is it sharp, chronic? Does it come and go? Is it a pressure? Is it sharp? Do you feel pain when you urinate or with a bowel movement? Does your period affect your pain or your cycles? Does anything make your pain better or worse? And we ask that a lot in this condition in urology. So the history, have they had any pelvic surgery, pregnancy? Have you ever been touched against your will? What treatments have you tried so far and have they worked? Are you being treated for anything, else? Are there any other health concerns? Or have you recently felt depressed, down, hopeless? So, a lot of times pelvic exams will help. It can find symptoms of illness, unusual growths, or tense pelvic floor muscles. Especially during a pelvic exam, when you're doing the pelvic exam, obviously this can be very painful for patients. A lot of times their pelvic floor is tight. So, obviously you want to tell the patient, speak up if you're feeling a lot of pain during the exam, because, we would want to stop if we're, obviously they're overly anxious or uncomfortable. What kind of lab tests do we do? I mean, there's probably a lot of tests, but we do the urinalysis and the microscopy and the urine culture because we want to rule out infection. We want to rule out that they have blood in the urine, because if they have blood in the urine, that's a whole different, aspect of looking at it. We would have to do further testing to find out why they have blood in the urine. STI testing, we wanted to make sure do they have an STD? Have they had a history of an STD? And of course, Vic did a great job doing an STI talk several weeks back that you can certainly go back to and watch. It's pretty interesting. And CBC is just to rule out an infectious process. There's also imaging. A lot of times when they present to our office, of course, a lot of these tests could have already been done, but an ultrasound of the pelvis and the bladder. We do bladder scans, obviously, to, check a post-void residual just to make sure they're not in urinary retention. I mean, I don't know how many times patients come in and they have pelvic pain and they're holding a liter, but they're still peeing and they don't really realize it, but it's still causing them this chronic pelvic pain. And then, of course, CT or MRI, and it can find growths or other unusual structures. Diagnostic procedures. When you're talking about chronic pelvic pain, these are some of the things that they may consider. They're not always done just to prove that they have, chronic pelvic pain, but you want to rule out anything that could possibly, be causing this pelvic pain, like a laparoscopy. I can't even say that word. Laparoscopy, thank you. Cystoscopy, sigmoidoscopy, and colonoscopy to rule out other factors that could be causing. So tests alone, like I said, may not be able to find the cause for the chronic pelvic pain. So in that case, the goal of treatment is to ease pain and manage symptoms. And that's what we're going to talk a lot about too. So, of course, you got medications. You've got pain relievers, you got Tylenol, you got ibuprofen. But, rarely does this get rid of the pain alone. Sometimes you have to use these in conjunction with other methods in order to relieve pain. Hormone treatments, pelvic pain may overlap, a phase of a menstrual cycle. So birth control pills and other hormonal medicines may help. You've got the tricyclic antidepressants, and even though you're not using it for, and for depression, it may help ease chronic pain even if you don't have the depression. You got muscle relaxers, you've got analgesics to treat bladder symptoms, and of course those are pyridium, our azo. We've got the Urabel, all the ones that kind of turn your urine a funky color, green, blue, orange, whatever it turns out to be. You've got anticholinergics. Those are the oxybutynin, you got Vesicare, you've got all those anti-spasm medications to stop spasms that could be causing, chronic pelvic pain. And then we have bladder installations, and we will talk about that in a little bit. So other therapies, physical therapy is actually, it's very common in our office to send somebody with chronic pelvic pain to physical therapy. And it's just to kind of teach the patient stretches, relaxation techniques, things like that to kind of help. Biofeedback, helps the patient become aware of areas where the muscles are tight in order to help strengthen and relax that pelvic floor that can be so tense. Spinal cord stimulation. The treatment involves implanting a device that blocks nerve pathways so that pain signals can't reach the brain. We don't use this too often for chronic pelvic pain, but it is an option, as well as trigger point injections, these are shots of numbing medication that actually help block the pain in the sensitive spots of the body. I don't see that very often as well. Talk therapy, obviously, some people with chronic pain may also have depression and anxiety. We see that all the time when they come into the office. Their list is, they may have IBS, they may have the fibromyalgia, they have the depression, the anxiety. You see all these factors. So talk therapy with a psychiatrist or a psychologist can ease stress and help you learn ways to cope with the pain. You've also got acupuncture, and of course, don't forget the almighty heating pad, which helps or even sits fast. So the lifestyle and home remedies, long-term pain can cause anxiety and stress, like we talked, which can, it can make pain worse when somebody's very anxious. I mean, even ourselves, when we're anxious or depressed, or we can tense up. And so, it can cause a lot of difficulty sleeping, exercising and doing everyday tasks. So we've got, don't forget about relaxation techniques, the simple stuff like meditation and deep breathing. And I know, meditation, you have to learn how to do it. It's not something that you're going to just go, I'm going to meditate, and it's a practice. I know I have a hard time meditating because, my mind wanders and so forth. But sometimes you realize how tense you are sometimes. I mean, even just sitting there, if you think about any muscle in your body, you try to relax them, you realize that you're tense. I realized when I go to the nail salon and get my nails done, I think I'm relaxed. It's a relaxing thing to do, but I'm sitting there, and then all of a sudden the manicurist says, relax your fingers, relax your toes. And I don't realize that I'm like in this tense position. Deep breathing helps a lot, obviously. And even with patients, when we have patients, you want to make sure that they're deep breathing, especially when we're doing something like putting a catheter in or dealing with something that's painful on their body. Good lifestyle changes. You got to practice good posture, lose weight, because it reduces the risk of straining joints and muscles in the pelvis. Regular exercise helps, diet helps, and obviously keeping well hydrated. Surgeries are, I threw a couple in here only because these are kind of some last resort when somebody has a lot of chronic pain. Hysterectomies, obviously, they could have fibroids and endometriosis and things like that cause chronic things that could help. Cystectomy, I actually have really only seen one cystectomy for chronic bladder pain. And it did help her, but you got to kind of weigh the risks. It's a risky procedure, number one, and sometimes it doesn't even help the pain afterwards. So we're going to kind of focus on chronic bladder pain, or, of course, as we know, interstitial cystitis. So chronic bladder pain is in the absence of identifiable causes. Of course, we got to rule out everything else. It's been historically called interstitial cystitis. However, there's no evidence that the condition is associated with abnormalities in the bladder. There is approximately 850 people per 100,000 women and 41 per 100,000 men that are affected by this condition. So it's quite a lot. It's suspected in patients who have pain perceived to be related to the urinary bladder for 6 months without a specific cause. A lot of symptoms, but here's some of them. So people with interstitial cystitis or chronic bladder pain, often when their bladder's filling is when they feel a lot of pain, and then they feel a lot better when they void. They have the suprapubic or urethral pain. They could have urinary frequency, urgency, and sometimes, they could just have urgency and frequency because of spasms, things like that. But often you'll find that people with this condition will actually void more only because they're afraid that their bladder is going to fill, because when they fill, they have more pain. So why don't you pee more often? You get burning, obviously dysuria, tenderness or tight pelvic floor. That's a big one. And then they can have the pain with sex. And again, IBS and fibromyalgia are often present. I remember, early on in my urology career that, everybody that came in with this bladder pain always seemed to have the IBS and the fibromyalgia along with it. So for an evaluation, the main goal of a diagnostic evaluation is just to exclude every other condition that can be causing the chronic pain. You got to make sure that there's nothing else that's causing it that you're missing. It is definitely an exclusion diagnosis. So again, the pelvic exam, what do we do? So we have to do a lot of times pelvic exams are used to rule out things. The findings include widespread tenderness of the abdominal wall, the hip girdle, buttocks, thighs, and the pelvic floor, as well as tenderness of the bladder, base, or the urethra. And the main objection is to rule out potential causes of symptoms such as pelvic prolapse. We've got the urethral diverticulum or polyp. You could have a hernia or even, uterine or cervical masses. So urine tests, again, we should be doing the microscopy to rule out hematuria or infection. And obviously, if they look like they have an infection, they can, obviously send out a urine culture. Now, one thing I do want you to know about, urinary tract infections, yes, we can treat them easily. But when you get a urinary tract infection, it actually damages the mucosa of the bladder. And if you have patients that continue to have symptoms after a urinary tract infection and you've ruled out by repeating a urine test that their urine is clear, it could take up to 6 months for that bladder to repair. So a lot of patients will have, antibiotics and feel great in 2 to 3 days, but others, these symptoms can linger up to 6 months. Again, STI testing and then the post-void residual to rule out the urinary tract infection. Patients who are suspected to have the chronic bladder pain or the interstitial cystitis generally are symptomatic, but all of their urine cultures come back negative. In a previous episode, they talked about guidance tests, and we actually will do guidance tests a lot. These are PCR tests that actually will grow out any bacteria in the urine and kind of decipher if antibiotics are needed for even the minute amount of bacteria in the urine. And sometimes this does help with these people. So diagnosing, so these are for select patients. You're not going to rush out and do a cysto for these patients necessarily. I remember way back when I first became a urology nurse, and the way to diagnose interstitial cystitis or bladder pain was to do a cystohydrodistension, where they overfill the bladder, they stretch it out, and you're going to see, possibly little hemorrhages or petechiae or even these Hunner's ulcers or lesions in the bladder. But it has been found that a lot of these are even normal bladders, when you hydrodistend them, sometimes can look like they have little, inflamed areas and things like that. So it's not as diagnostic as we once thought. Urodynamic testing, it can be, we don't like to do it because it can be painful for the patient. And what is it really going to tell us? It could tell us, if, maybe one of their symptoms might be along with chronic pelvic pain. Maybe they have some urinary incontinence. Maybe they don't empty their bladder well, so you want to look for other causes for that. But it does give you a little bit, it could give you a little bit of idea if they have a pelvic floor dysfunction by the EMG that we do during a urodynamic study. So what can we do? And mainly it is symptom management, but there is an oral medication called Elmeron. It is the only medication that will actually repair the surface of the bladder. We have, of course, the tricyclic antidepressants, which is the amitriptyline. I believe that Cymbalta and Effexor can help as well. These medications can relax, the bladder, and you can use it for a dual diagnosis. Maybe they do have some depression and anxiety along with the bladder pain. Analgesics for the bladder symptoms, we talked about that. Those are the ones that turn the urine a funky color. We got the azo, the pyridium, the urel, the urabel. We have the anticholinergics, which is a long list, but the oxybutanins, the Vesicare. We also have Myrbetriq and Gemtesa out there now. And antihistamines, the hydroxyzine, Benadryl, Claritine. These can all help relax the pelvic floor, and these can help reduce spasms, which can lead to urinary frequency and urgency. Now, as far as supplements are concerned, these are actually new to me. I just learned these last week when we were discharging a patient. We give an after visit summary to patients, and one of the doctors put these supplements, and I thought it might be interesting to add. but horsetail root, marshmallow root, hemp oil, and Healthy Life Harvest aloe. All right, so we got the bladder installations. Who doesn't love DMSO? So DMSO reduces bladder inflammation and pain. And so it is a bladder installation. What we do with the bladder installations is we instill a 15 French red rubber catheter. It can be, but consider the size. If they're in a lot of pain, we've gone down to even 8 French to instill these. And we just, fill these medications up with a Toomey syringe. And then we just push it into the bladder, and the patient holds it for about 20 to 30 minutes. Now, what we do for our patients is we also, use the Glido gel or lidocaine gel, and we instill it. We don't necessarily use those gels in women per se, but especially when they have bladder pain or discomfort, urethral pain, things like that, we will use Glido. We've got, one thing about the DMSO, if you all haven't used it before, it smells like garlic, and patients can actually, people can actually smell it as it absorbs through their skin. And they also sometimes they complain of like a garlicky taste. We also use bladder cocktails. We in our office call them rescue solutions. These could be a number of things: a lidocaine, marcaine, obviously, the numb the bladder. We use heparin that helps to repair damage if there is any damage to the bladder's lining. It has an anti-inflammatory action. Sodium bicarb. We use a little bit of sodium bicarb in some of these solutions because it increases absorption into the bladder lining. Kenalog or triamcinolone, and that also gives an anti-inflammatory action. These treatments can be given on an as-needed basis, especially these rescue solutions, if they have a flare of interstitial cystitis, or a flare of symptoms, I should say. I know DMSO, a lot of times it's given once a week for a period of 6 to 8 weeks. Some people, I've had patients come in every week for these rescue solutions or bladder cocktails. But again, it's a trial and error. Some people claim it works, and some it just does not give them relief. So we've got other ways to manage. We, of course, our good old bladder irritants. And these are just some of a list of bladder irritants, but are probably the most common, and that's alcohol, spicy foods, caffeine, citrus, carbonated beverages. Don't judge when I'm drinking my Diet Coke right here. We've got artificial sweeteners and chocolate. Darn. Bladder training, these patients, because they go frequently, and sometimes they have a smaller bladder, or they're peeing because it's painful for their bladder to fill, should probably practice to try to hold their bladder a little bit longer for periods of time. This could be even holding it instead of, they can only hold it for 1 hour, do 1 hour and 15 minutes, 1 hour and a half, and try to increase it a little bit. Vaginal Valium is used sometimes. That's actually something that comes from a compounding pharmacy, and I don't remember, but I know that back in the day we used B&O suppositories. Not sure if they even have those anymore. So we see a lot more the vaginal Valium more now. And again, physical therapy to try to help them relax those pelvic muscles, to learn how they can relax them, especially when they have a very tight pelvic floor. The relaxation techniques we talked about, exercise and diet, the hydration, bladder hydrodistension. We do have a few patients that claim that doing a bladder hydrodistension and extending or stretching that bladder will actually help their symptoms. So they come in occasionally, not often, maybe every few months or what have you, to go ahead and stretch the bladder out a little bit. We've got the neurostimulation. We've, again, the cystohydrodilation, same thing as the bladder hydrodistension. And then, of course, if, last resort, last, this is that cystectomy, which, like I said, you don't see too often. All right, what about men? Men have chronic pelvic pain too. So chronic pelvic pain syndrome in men is a clinical syndrome defined by pain or discomfort in the pelvic region, of course, often accompanied by urological symptoms or sexual dysfunction for at least 6 months. They have an increased tension and difficulty relaxing the pelvic floor. And the etiology in many males with, or those are likely the etiology in many males with chronic pelvic pain. Evidence suggests that prostate inflammation or prostatitis is a primary cause of the condition are conflicting and nonspecific. And again, I remember way back in the day that everybody who, men who came in with pelvic pain, what would happen is if it's not an acute prostatitis and they have this chronic prostate pain, they would basically put them on long-term antibiotics. They're trying to get away from that, just like, anything else that's given antibiotics. Why give antibiotics when, they can become resistant and they don't necessarily always help, especially if that prostatitis is not bacterial. So what are the symptoms? We've got the perineal pain, we've got testicular pain, we've got suprapubic area, and the penis pain. Obviously, when somebody presents and they're having any kind of testicular pain, most times you'll want to order the testicular ultrasound to rule out other reasons why they could have the testicular pain. You're going to do those urine tests again, STI testing to rule out, infection and things like that. Their symptoms can also include the frequency, the urgency, the dysuria, painful bladder filling sensation. So again, pain with bladder filling, and they can have pain with ejaculation. So physical findings, sometimes they can have, mildly tender prostate. I know that when this just happened a few days ago, where a doctor said, "Oh my gosh," and this guy came in with pelvic pain, and he tried to do a rectal exam, and these rectal exams to check the prostate aren't always diagnostic, of course, of anything. But he's like, I couldn't even get my finger in his rectum. His pelvic floor was so tight that he couldn't even get his finger in. And I'm sure we've all experienced that before with even catheters, how men just tense and they just tense up so bad that you can't get a catheter in. They'll have muscle spasm or muscle tenderness upon palpation of that perineum, pelvic floor, and the pelvic side walls. There really is no lab or imaging findings associated with chronic pelvic pain in men. It's, again, a lot of these chronic pelvic pain are based on symptoms. So what do we do with men? It's a little bit different. We still use the NSAIDs. They can use Tylenol, but NSAID seems to work really well, especially if there's any kind of underlying inflammation. So I obviously have a typo there. Ibuprofen, 400 milligrams TID, 3 times a day for 1 week. We'll use alpha blockers like tamsulosin. It could be just a temporary, or it could be long-term, but for about 6 weeks, just to kind of relax the pelvic floor. And, like alpha blockers, now we find are good in many things. Tamsulosin would be, to help them urinate. It helps them urinate better, but it actually helps relax the pelvic floor as well, the urinary tract, and that's why we use it in kidney stones as well. We use daily tadalafil, not only for maybe erectile issues and things like that can be associated, but along with the not with the alpha blocker, but it also has effects of an alpha blocker. That's why we use tadalafil now in men to help them urinate as well. The phosphodiesterase 5 inhibitors for sexual dysfunction, of course, the Viagra, the Cialis, the Levitra, things like that, and the tricyclic antidepressants. We instruct them they can use sitz baths to help with a lot of these symptoms, and the physical therapy for the pelvic floor dysfunction, cognitive behavior therapy, the relaxation techniques, acupuncture, diet, and exercise. So in conclusion, chronic pelvic and bladder pain is an exclusion diagnosis. The cause of chronic pelvic bladder pain can take time. A clear reason may never be found. Focus is on management of symptoms after ruling out any treatable causes. And it may take a combination of treatments before you find what works for your patient. So just be patient. We instruct our patients to be patient. We have to be patient too to find something that works for them. Thank you very much. And now I will take any questions.
Nicely done, Lori.
Thank
Yeah,
you.
great job. Lori, I just got to tell you right now, you're blowing up on Twitter. And all you Twitter viewers
It's
out
all
there, thanks
those
for joining.
pelvic pain chronic patients that don't
Like
know what to do.
50 people watching live on Twitter. Thanks for all you Twitters joining us. This first time
Thank you, everybody.
number show up. Unfortunately, I just tested it. You can't use your comments to send questions from Twitter, I guess. But I've never had a big crowd from Twitter before. So I encourage you guys, if you like the show and want to keep watching, to go ahead and tune in on either YouTube or our Facebook page, or go right and subscribe to our episodes through StreamYard. That's the best way to get questions on. So anybody with questions, feel free to put those into the comments section and we'll take those. I had a couple things I was going to mention, Lori. So one of the things I think all of us that have been in urology for a long time, these are patients that, as John kind of led into, the dreads of urology. And we say that because not that we really dread a patient, but they go from doctor to doctor. You're rarely seeing them for the first time. You're my 10th urologist, and I know I've got prostatitis for men. It's prostatitis, and I know I just need Cipro and I'll be fine. And it's just a lot of poorly diagnosed patients that you've tried everything, and as Lori kind of talked about, there's a lot of treatments out there. Some that I think have some good evidence, and a lot of them which I just call, just voodoo medicine. It works, but hydrodistension, I don't know that there's any really good studies to explain why it works, but I can tell you there's patients that have succeeded from it. I think that the new testing with the DNA for cultures have revealed some prostatitis organisms that we've treated and actually had some success. So you try everything, but that's my comment. Is it's tough to be that kind of a patient.
Yeah, I remember a long time ago, and I worked with a doctor who really dealt a lot with interstitial cystitis. That's what it was diagnosed at the time. And I remember telling him, because I was so new, I was like, are these people who come in, are they all crazy? Like, they've got all this anxiety and they're on all these drugs and things like that, and even painkillers and things like that. And he goes, a lot of people do present, they have the depression, anxiety, but you got to keep in mind that this chronic disease can cause them to become anxious or depressed. So I'll never forget that, because then I look at it a whole different way.
Yes. I wonder if sometimes it's the chicken or the egg. Are they really high-strung people more prone to having, these type of symptoms, or having these symptoms is enough to make anybody kind of high-strung?
Well, I can tell you right now, after putting this presentation together, one night I was sitting there and I'm like, wait, I'm feeling pelvic pain. And I'm like, is it just because I just put this together or what?
There you go.
Similarly, for a lot of guys, they had one episode of epididymitis, and then now they're fixated down in the scrotal area. So I see quite a few of those guys. When it comes to IC and, in essence, bladder pain syndrome, we have to keep in mind that we as scientists, clinicians, we want to just pigeonhole, bucket the patient. Unfortunately, often it can involve different parts of the patient. And this very serendipitously, this book was just sent to me without solicitation. Dr. Jill Peters-G, IC Journey to Wellness. No financial relationship. She just sent it to me. I read it in one night. Very good, comprehensive, updated book on chronic pelvic pain, bladder pain syndrome, and IC. It's often not just the pelvic area. It's not just the bladder. It could be areas around the bladder. It could be from the central nervous system going down into the bladder, or sometimes it could be inside the bladder. So the workup evaluation needs to involve all three components. And I like how she characterized the condition as having different types of phenotypes, and often these phenotypes overlap. So taking a multi-factorial approach is very important. getting a good history on these pelvic pain, bladder pain, penile pain, perineal pain type patients is imperative. That often leads to the appropriate workup and suggestions on the appropriate treatments.
Yeah, absolutely. The one thing you mentioned was the foods that can be bladder irritants, and sometimes that's overlooked. It's the simplest thing to do. Just eliminate these foods. I tell patients, stop them all for 2 weeks. Give yourself a washout period. If your symptoms get better, you're golden. Then just introduce each one of them separately. When you suddenly find the one that's triggering or the ones, then just keep that out of your diet. And of course, that relief is worth it. Now, if you want to get that diet, you can go to the europatient.com website and download the bladder irritant diet. It's available there for you.
Yeah, I know we probably all had those patients come in and we give them that bladder irritant sheets that has a million things. And they're like, I can't have this and I can't have that. And I said, and I always tell that, I'm like, I am not telling you that you can't drink your coffee or drink your Diet Coke. I am just saying that if you do, this could be a trigger for those symptoms.
Absolutely. Have you referred patients out, John, to physical therapy?
Oh, absolutely. I was just gonna say that. First of all, that physical examination is extremely, extremely important. Other than getting a good history that gives you a guide as to what to look for, doing that physical examination is going to reveal so much information, especially for that female pelvic examination. Is it really the bladder? And often I'm doing a cysto and the pelvic exam at the same time. So is there something inside the bladder? Often you don't see the Hunner's ulcers, glomerulations. You don't often see that. And I would suggest that you distend the bladder enough, you're going to see some glomerulations. But when you do the physical examination, the pelvic examination, identifying areas where there's point tenderness, especially in the muscular areas, muscular attachment areas in the pelvis. And if you touch that area, could be anterior, could be posterior. If you touch that area and the patient feels, oh, ouch, and grimaces, then you may think, this may have a muscular component to it. And I've referred to pelvic floor physical. And finding a good pelvic floor physical therapist in your area. There are few pelvic floor physical therapists. Yeah, these pelvic floor physical therapists, they specialize a subspecialty in pelvic floor physical therapy. Find those folks in your area. And I refer quite a few of my patients to those therapists.
Yeah, I would love to get a physical therapist, a pelvic floor physical therapist on uriners, just because that's kind of a talk in itself. Be very interesting because I don't know a whole lot of actually what they do as far as the biofeedback or what they hook them up to and how they have them identify things. It would be really interesting.
I had one chiropractor who was seeing patients for this, male patients for pelvic floor dysfunction, that type of, that constant frequency urgency. And he said he had a lot of good success from a chiropractic technique. I think anything that works is great. And I don't think any one thing is going to work on everybody. This is, like we said, this is one of those tough things to deal with.
How do you guys, with experience with the bladder installations, how do you find those? What do you guys typically use or see, or you guys? Because everybody has kind of their different cocktails or their little, what do you think works for you?
We use the cocktail the most, the combinations of things like even the lidocaine just given by itself, a lot of times will give a lot of relief. We find that. I don't know that they've tried anything like Botox. I haven't read anything in the literature, but I'd be surprised that might not give some relief too. Although I don't think that these irritative bladders really are overactive, because I did a lot of urodynamics. And one of the things I always could tell when I was filling a patient's bladder up is they would be like 100 cc max volume that they would hold, but you wouldn't see a detrusor contraction. You would just have this urgency to go, a feeling of it.
Right.
Yeah, unfortunately, our understanding of, well, first of all, what is it? We don't really know. Is it the gag layer that's been assaulted or insulted or damaged, or is there something else going on? Is there some sort of a weird bacteria that is not typically detected on the standard urine culture, or is there some sort of inflammatory situation going on, or it could be a combination of many different things. Unfortunately, we don't have a, go ahead.
I was going to talk, so the Elmeron obviously is a medication that's used out there to try to repair that layer or build it. I know that Elmeron, you used to see it all the time, but we don't use it as much anymore. And I think it's probably because the side effects, patients don't like it, because guess what? When you hear that you could have hair loss, you'll lose a lot of people, and it takes a long time, and it's a long-term medication.
Yeah, talk about what a great way to sell medication, right? Only about 50% of you will improve with this medication, and you have to take it for several months. Most recently, it's been discovered that patients taking this medication may suffer from what's called pigmentary maculopathy. So you may want to consider having your patients getting their eyes examined prior to and also after starting medical therapy using Elmeron. And go ahead.
The one thing you can do with Elmeron too is you can actually use it as a bladder installation. Take the Elmeron out of the little capsules. The physician that was really big in this, I can't think of what his name is right now. I actually met him at one of the AUAs, and he said, start using it as an intravesical treatment. And I had some success with that. Like everything else, some success, not all. I did get a comment that came in from April. We have an in-house pelvic floor physical therapist. Patients love it and report great results. So there you go. I think there's a lot of patients that will benefit from the proper physical therapy.
And I think one of the things that I would foresee, that pelvic floor therapy obviously is not a one and done either. So sometimes it's hard for people because they work or what have you to actually be consistent with it. And that's one of the hard parts about physical therapy, is having to be consistent with it.
For everything, all physical therapy, you just don't go there and they magic wand and you're healed. It's a routine of what you have to do to prevent.
Yep. I'll tell you a little story about in this. I was going to talk about a little bit, and I forgot to mention the story that I had. And when we talk about ruling out other causes for the pain, we had a male come in, and he was having this chronic pelvic pain, and treated this way and that way and that way. And something as simple as doing a urine test is so crucial, because he had blood in the urine. And so then he ended up having, a workup. And guess what? They found a kidney stone, and it was causing his pelvic pain. He didn't have the traditional flank pain. He had the, pelvic pain. And you don't want to miss out things like bladder cancer either that could be causing these problems, and blood in the urine. So if you see blood in the urine, make sure you've got a microscopic, exam, and then work them up for that if they do.
Absolutely. Yeah, often
the
distal ureter, if you have a stone in the distal ureter, it can give you that frequency, urgency, microscopic or frank blood in the urine, and also sometimes with or without flank pain. So you have to think, well, the symptoms are in the bladder, but then the actual cause is in the ureter. Sometimes the prostatitis, inflammation of the prostate, can cause referred pain or discomfort, typically towards the tip of the penis, in the distal third of the penis. So often when patients come in with penile pain or urethral pain, I have to think of not just the exact area where he's complaining, and I have to think about from where that pain can be referred.
Yep. Absolutely. And I think as we talked about, you need to have a thorough exam. I remember a patient, she was in her 30s, who was coming in with all the classical symptoms of what you would say, was probably just this interstitial cystitis or something like that. Or she was coming in saying, I'm seeing you because I need my antibiotics. I get chronic urinary tract infections. Well, when we did the workup, her cysto revealed a bladder tumor. So you don't expect a non-smoker. I mean, some people always say, how did I get cancer? I said, bad luck is one of the causes.
Yeah, definitely. I recently diagnosed a very young, someone in his 20s with bladder cancer. And I said, there's no way. You come in with blood in the urine. I said, yeah, most of the time this workup shows nothing. And then I look in the bladder, I see a tumor in the bladder, I resected the tumor, it turned out to be bladder cancer. Someone with no risk factors.
Yeah,
And like
we
you
have
said, Vic, it's just bad
we
luck.
currently have a lady in her 30s that unfortunately she's on hospice, and it's
Oh.
it's so sad. Yeah.
But anyway, thorough workup, getting a good history, and leave no stone unturned. And and if you are after this whole workup, those of you who are watching, look up one of these books, one of the recent books, something like this, and I put the link to Amazon in the comments area on X, and I shared this on X, by the way. And maybe that has something to do with it.
Yeah.
We'll
let's
link
not
that
forget-
information.
Let's not forget about support groups too. You know,
Oh,
there
huge.
are many support
Yeah.
groups out there for this chronic pelvic pain, interstitial cystitis, or whatever, that do help patients, you know,
Yeah.
get together with other people who are struggling.
Tons of Facebook groups and support groups that you can join. And speaking of Facebook groups, we'll be talking about that in a couple of weeks.
That's right.
Yeah, right. Social media, it's the way to find out the information you need.
Good
So
or
let's
bad?
go talk it good and bad. That's right. But it's always good to learn as much as you can if you're having a problem. Let's talk about next week. We're going to have an interesting show, something new. I've actually hooked up with a company that's going to allow us to use a video that they put out on overactive bladder, and it's going to have a contact hour or CME. So either way, for free, that you can get with that. Here's a little plug.
Join your own nurse for a shared viewing of a webcast, which captures the proceedings of a live CME CE symposium held during North Central Section AUA 2023. Led by renowned experts in urology, this educational activity covers a spectrum of topics, including diagnostic approaches, behavioral therapies, and pharmacologic treatments. By enhancing their understanding of OAB pathophysiology, diagnostic nuances, and therapeutic options, clinicians will be better prepared to devise personalized treatment plans and improve patient outcomes of diverse patient populations suffering from OAB. At the completion of viewing this, you will be able to submit for free 1 AMAPRA Category 1 credit or 1 ANCC contact hour. Join your own nurse for this unique experience this Saturday.
So there you have it. I hope that everybody joins us next week to try this new thing out, this shared viewing of a contact hour type view. And with that, hey, it's a beautiful weekend this out here in the Chicagoland area. A little hot by John, I hear, but get out and enjoy this great start of the summer. We'll see everybody next week on Euronurse.